So now we are going into the realm of sonography in ICU. So none better than two excellent speakers in this aspect, Dr. Shrikan Srinivasan, who is the head of the department critical care from Manipal Hospital, Delhi, and Dr. Anand. Dr. Shrikan Srinivasan is an expert in ultrasonograph, point of care sonography, and he was awarded twice a presidential citation by Critical Care Medicine, Indian College of Critical Care Medicine. He is also an associate editor of Indian Journal of Critical Care Medicine, and he was already also awarded the FICCM. And discussing with him and going into pros and cons of sonography in ICU, Dr. Anand Gupta. Dr. Anand Gupta is a clinical director and senior consultant from AAG Hospital, Hyderabad. Over to you both. Thank you.
Good evening, one and all. Myself, Dr. Anand Gupta. Today, we are going to discuss our role of ultrasound in critical care. As we know, as an intensivist, the ultrasound is very important tool for the intensivist, for making a diagnosis, for doing the procedures, for assessment of the patient on organ failure. Because it's a point of care procedures, it can be repeatable, cheaper, no harm. And so the ultrasound has many role in the critical care part. So today we will discuss where it can be used in the ICU. So for discussing all these things today, we have a very eminent teacher and expert in ultrasound, Dr. Shrikan Srinivasan, sir. He is my senior and my teacher also. He is the head of the department in Manipal Hospital, Delhi. Welcome, sir.
Thank you, Dr. Anand, for that very kind introduction. And as this topic is use of sonography in the ICU, I mean point of care ultrasound in the ICU, this is a rather vast topic to be covered in 20 minutes, but I and Anand will try to do some justice to this. So go ahead, Dr. Anand, you can start asking the questions.
Yeah, without delay, just as we are seeing in the last 1.5 years, most of the patients are COVID patients are receiving, and they are mainly hypoxic. Non-COVID also, the mainly in the ICU, they are hypoxic. So just I want to know that what is the role of lung ultrasound in the diagnosis of the hypoxamic respiratory failure, sir?
Yeah, this is a very pertinent question, and since ultrasound has permeated most of the aspects of ICU care, in fact, it is the power tool in the hands of intensivists and the go-to device which we use as a part of clinic to augment our clinical examination and to get to some kind of diagnosis and to confirm and monitor the patients as well. So it is diagnostic, therapeutic, and monitoring all three together. So this is one single tool which does all the three. Now the question which you asked me is hypoxamic respiratory failure. So I would like to share a couple of images if you permit. So Dr. Anand?
Yeah, sure.
So if we I go with the premise that some people are already doing lung ultrasound. So effectively, what we can do is we can, based on the findings on lung ultrasound, we can actually divide the lungs findings on different kind of profiles. So profiles is what is the predominant feature which is seen on lung ultrasound while scanning the entire chest. The most common feature which we see is right here. This is the A profile, which we see is that now which is basically A lines with preserved lung sliding. So if you see this kind of a picture, both sides, your lungs are aerated, right? So we may have another kind of profile, which is the A dash profile. Here again, you see A lines without any kind of sliding. So this suggests that there could be a pneumothorax here. Diametrically opposite, you have what's called the B profile, which is presence of predominantly B lines in your scan image. So as you can see this, and a B dash profile is B profile with impaired lung sliding. Now B and B dash are seen in classical conditions. B is seen in what you say in a congested hydrostatic pulmonary edema kind of a picture where there's too much de-aeration of the lung and a lot of fluid in the lung. So there you can see a B profile, that is B lines with lung sliding. A B dash is basically B lines with very diminished kind of lung sliding. And this occurs in inflammatory edemas. Inflammatory edemas as in any kind of infection, interstitial pneumonia, ARDS, contusions. So all those leads to what's called the B dash profile. And finally, we have a consolidation profile or a C profile, which is there. So based on this A, B, A dash, B dash, and C, we can actually go ahead and classify the major findings on our lung ultrasound. We can always, for hypoxamic respiratory failure, we can always go ahead and use the blue protocol, which is basically a rapid scanning of the lungs to see whether, first of all, lung sliding is there or not. if it's present or is absent, and if it's there, what kind of A lines or B lines or B dash, or what is available, or a C profile is available. And based on this flow chart or a stepwise approach, we can come across the diagnosis of pulmonary edema, pulmonary embolism, pneumonia, pneumothorax, possible pneumothorax, with an accuracy of almost 91% based on lung ultrasound findings alone. Now, obviously, this is just a part of your diagnostic workup. So obviously you need to have history, clinical examination, biochemical values and all that. And all those will get the diagnosis close to 100%. So this is a 3-step approach. Look for sliding, look for the predominant profile, which is there, A, B, B dash or C. And then if you don't find anything anteriorly or laterally, go posteriorly and look for consolidations. So this is how we approach a patient with hypoxemic respiratory failure.
So most of the lung condition which causing the hypoxia, we can identify with all these within a 5 minutes by putting the probe.
5 minutes by this 3-step approach. First of all, first sliding is there or not. Look for the predominant profile which is there in the lungs. And then if you don't, and look anteriorly, look laterally, look posteriorly. If you don't find something in anterior lateral, look posterior. And based on that, you can go into a flow pattern in which you can, everything is a part of the puzzle. You have to fit the picture into the puzzle, and then you have to come across diagnosis.
There's one question arises, sir. Is there just like a bilateral B-line we are finding in like a pulmonary edema in the congested lung is there. So can we quantify this amount of the lung through the lung ultrasound, sir?
Yes. See, there is a very classical signs that lung ultrasound, basically the presence of B lines, which denotes deaeration, sort of tells you that there is some amount of deaeration of the lungs. There's increase in the fluid component of the lung. And it is by counting the number of B lines, it's like a semi-quantification. See, a semi-quantification means that you are seeing the B lines appear where they were not there in the first place. If it is purely gravity-based or hydrostatic pulmonary edema, as it occurs because of excessive amount of fluids, or it occurs because of cardiogenic pulmonary edema, basically left-sided heart failure, there you will see gravity-based B lines which start posteriorly, come laterally, and as the congestion increases, come more anteriorly. So based on where you're seeing the B lines in the background of pulmonary edema, it tells you how severe the pulmonary edema is. See, you may have initially lines only posterior, then lateral, and then finally anterior. If you have anterior B lines as well, and a gravity-based distribution of B lines, anterior being rarer and lateral being more denser and posterior being very dense, it tells you that the level of congestion is extreme. Once you start your therapy, you see disappearance of B lines, starting from anterior, going to lateral, going posterior. So this tells you that you are on the right line of therapy and things are improving. And mind you, this response occurs a lot before there is a change in your saturation, there's a change in the overall clinical condition. So that's how sensitive lung ultrasound is with regards to level of congestion of the lung. When you talk about fluid overload or hydrostatic pulmonary edema, we know that inflammatory edemas take much more time, but this semi-quantification of B lines really does help because they appear and disappear pretty fast.
So how will you differentiate, sir, with the cardiogenic pulmonary edema and ARDS with lung ultrasound, sir? Yes.
So I'd like you to look at this very classical differentiating table, which tells you how to differentiate between acute cardiogenic pulmonary edema, and which is hydrostatic, gravity-based, and non-hydrostatic or inflammatory pulmonary edema, that's ARDS or interstitial pneumonia. Predominantly, the difference comes on the basis of whether the distribution of B lines are gravity-based or non-gravity-based. If you have a gravity-based distribution of B lines, well, first and foremost, you understand there is some kind of hydrostatic pressure which is working, because obviously the areas which are below the level of the heart, that is the posterior part of the lungs, are the most congested, and then comes the lateral and comes the anterior. On the other hand, inflammatory edemas, as it occurs in ARDS or in interstitial pneumonias, there it doesn't really necessarily follow gravity. You may have a lot of B lines anteriorly and relatively spared pattern posteriorly. You may have A profile posteriorly and predominantly B lines anteriorly. And besides, ARDS classically or interstitial pneumonia is a very patchy kind of a disease. You have areas which are florid B lines, areas of consolidation, areas of normal lung, which are all totally mixed and matched and interspersed and do not follow any gravity-based distribution. So gravity-based distribution would be the first distinguishing feature. The other thing is obviously the profile. We have in hydrostatic pulmonary edema, we have a B profile, that is B lines with preserved lung sliding. On the other hand, in ARDS and interstitial pneumonias, we'll have a B dash profile. That is a B profile, B lines with diminished lung sliding. Why? Because of the inflammation, the pleural line gets kind of tethered, so it does not move that freely. And besides, in ARDS, we also have certain classical features of ARDS. I'll show you that like this. So if you see this kind of a picture where the pleural line appears to be shattered and there is non-homogeneous B lines which are appearing, irregular and fragmented pleural line, there are certain small subpleural consolidations, and they are non-homogeneous B lines. When I say non-homogeneous, I mean non-gravity based, mix and match, areas of spared areas, areas of normal areas. This is classical ARDS. This is what you see. If you find this kind of a picture, this is more likely to be ARDS rather than hydrostatic pulmonary edema.
Okay, so this is a very classical feature, sir, in this.
Yeah, this is a very classical feature of ARDS. If you find this while you're scanning bilateral B profile and you see this kind of a picture, this is mostly ARDS or interstitial pneumonias.
So most of the hypoxemia you have already discussed. Just I just want to know, what is the role of ultrasound in the mechanical ventilated patient, sir?
Yes. So in mechanically ventilated patient also, ultrasound has a lot of role. Actually, we can fine tune the mechanical ventilatory strategy based on what we find on ultrasound. We can use it to fine tune a ventilatory strategy to adjust the PEEP, to decide which is the optimum strategy, whether to prone the patient or not to prone the patient, and to detect complications like pneumothorax immediately. And most importantly, it helps in the time of weaning from mechanical ventilation. Now, if I want to take it stepwise, how does it help? First and foremost, you have a daily assessment of the degree of aeration, deaeration, right? You have what's called you can have a objective assessment of the same by doing what's called the aeration, deaeration score. Basically, you divide the lung into 6 zones, 2 anterior, 2 lateral, 2 posterior. So 6 on one side, 6 on other side. And you quantify the major pattern which is seen in each of these zones. Each of these patterns are given a specific number. And based on the total score which is obtained, we can say whether this lung is at this score, and after applying some amount of PEEP, whether the score improved or not. So that tells whether the patient is PEEP responsive or not. During time of weaning, when we are removing the patient from ventilator, putting on a T-piece, we can do an aeration score just prior to putting on a T-piece and after putting on a T-piece, and you see the de-aeration which occurs. Quite often than not, there's a lot of de-aeration which occurs, which we do not realize. The patient may pass a weaning trial, but eventually fail extubation. So this happens because there is a lot of de-aeration which occurs, which we do not see. So with this with this objective score, we can actually pinpoint those patients who are going to benefit with some kind of positive pressure ventilation post-extubation as well. So that's how lung ultrasound helps in. There's a very good article on that, lung ultrasound monitoring for the ventilated patients, and these are the various subgroups in which it helps.
So even in the ventilator patient, we can assess the lung is improving and it will helpful in the extubation also, sir. Yes,
so exactly. During the weaning time, that is a very, very important time where we can actually use it, and we can use a score to support our weaning. So if we have a de-aeration which is significant, we have a significant de-aeration which is basically changed from here to something like this, as you can see. And then we know that this patient is probably not a good candidate for extubation. This patient needs to be made more negative. Some negative fluid balance has to be achieved. And at the same time, this patient may require some kind of pressure support or some kind of a CPAP or a BiPAP post-extubation, so that some amount of PEEP is still available to the alveoli to keep them open.
Because sometimes we saw the X-rays in the last 2 or 3 days, X-rays doesn't change much actually. But the score is changed. According to this, the scoring may be changed. So ultrasound is more better predictor as compared to the X-ray actually.
Definitely. You see changes like increasing haziness, basilar haziness on day after extubation. You see that bibasilar, some amount of haze appears, and this gradually the haze increases. This is usually because there's a lot of PEEP loss. So you have suddenly extubated a patient, who was on positive pressure ventilation, to totally spontaneous breathing. So there is a good subset of patients who will deteriorate, who would have otherwise benefited with some amount of positive pressure. So those are the patients whom we can identify using this aeration, de-aeration score.
Thank you, sir. Just one more question, sir. What is the role of ultrasound in the shock assessment? Actually, there are many kind of shocks are there. The lung. What is the role of ultrasound, sir?
So a very pertinent question which you have asked. Anand. So when it comes to shock, ultrasound is the power tool. It is the go-to tool. Basically, bedside echo is the go-to tool which everybody uses, because we know that in the ICU setup, at least, different kinds of shocks can coexist, right? You can have a combination of cardiogenic and septic shock at the same time. So you can have a patient who is hypovolemic, and on top of that, he becomes septic. So there's a lot of mix and match which occurs. So to stratify shock as per what is the type of shock, so bedside echo plays a very, very major role. And there's a way to approach these patients with shock, because we know that every minute of shock which goes on, the morbidity and mortality of the patient increases way high. So there are a lot of scoring systems which have been designated, and not scoring systems. Sorry, there are certain protocols which have been made, especially for approach of patient to shock. And one such protocol which is quite popular is the RUSH protocol. The RUSH protocol is rapid ultrasound for shock and hypotension. So what it does is basically divides the entire examination into three major subgroups. Examination of the pump, which is basically the examination of the heart. Okay, you see whether the heart is pumping well. Is it hyperdynamic? Is it hypodynamic? If the contraction is poor, is the contraction good? Is the contraction impaired because of pericardial tamponade? So you see how the heart exactly is pumping. So that is the pump. Then we come to the tank. The tank corresponds to the vessels, which is especially the IVC assessment, or wherever the fluid tends to leak. For example, in hypovolemia, because of trauma, you may have a lot of blood loss within the abdomen. You can have a lot of blood loss within the thoracic cavities. So you can see collection of fluid in the peritoneal or pleural cavity. You can assess the IVC to see whether it is small or large. So that is the assessment of the tank. And finally comes the assessment of the pipes. The pipes basically refer to the deep veins. So deep veins and the aorta. So aorta may have an aortic aneurysm or a dissection, and there may be deep vein thrombosis. So based on a divided approach in the form of pump, tank, and pipes, you can divide or classify the shock into hypovolemic, cardiogenic, distributive, or obstructive shock. Now, how do we go about it? So when we talk about the pump, the first foremost step is we look for pericardial effusion. Why? Because pericardial tamponade tends to kill very fast. With minimal amount of fluid, if it collects very rapidly, the patient can rapidly deteriorate and die. And that is rapidly amenable to therapy, which is also going to be ultrasound guided. So first step, look for pericardial effusion. If the effusion is present, are there signs of tamponade? Now, what are the signs of tamponade which you can see with an echo? We see a mid-systolic collapse of the right atrium, which is the first sign. Normally, the right atrium will distend during ventricular systole, right? It fills up during ventricular systole. But if you see the right atrial collapse during a ventricular systole, you know that the right atrium is unable to fill up because of the fluid there. Second, a diastolic collapse of the right ventricle. So normally during the diastole, the right ventricle should dilate, should become larger. But if it collapses, it says that the fluid is compressing the right side of the heart and it's not allowing the ventricle to fill up at all. So these are the signs of tamponade which you see. And if you have a mid-systolic collapse of the right atrium or a diastolic collapse of the right ventricle on the background of a distended IVC and there's fluid around the heart, this is tamponade. And we have to deal with it first. Drain it, things will improve. Then second step, look for the LV contractility, whether it's hyperdynamic, normal, decreased. And if it's decreased, whether it's global or is it regional. Global has a different reasons. Regional is most likely because of an acute coronary syndrome, an acute event which causes regional wall motion abnormalities. And while we're looking at the contractility, we can also calculate what's called the velocity time integral, which is a surrogate of your stroke volume. So a velocity time integral is usually around 18 to 22. Anything less than that would say that the stroke volume is hampered. The stroke volume can be hampered because of poor preload, poor contractility, or increased afterload. So that's how you start the ball rolling, by trying to see what is the primary cause by which your stroke volume is reduced. Thirdly, you can assess the RV function. The RV function is predominantly eyeballing. You can see whether the right side, normally the right side is 1/3 of the left side. So anything which is above 1/3, even half or equal to the left side, says that the right side has been enlarged. The right side gets enlarged because of a pressure or a volume overload, and that leads to a septal deviation towards the left, and that leads to decreased left ventricular filling and shock. This occurs very often, especially when we are dealing with patients of ARDS, when we are dealing with giving high amount of PEEP. Sometimes the patient may go into what's called acute cor pulmonale. So the patient may be in shock once you put the patient on ventilator, and there could be multiple reasons for that shock. One reason being, obviously, you're giving hypnotics, you're giving sedatives. So the sympathetic drive is finished. Second, the patient the underlying hypovolemia could be unmasked. The third thing could be an increase in the thoracic pressure because of your ventilatory settings. So that is something which we quite often don't look for. So that is something which we can do on the bedside echo, and it will never get corrected till the time you know what the cause is. So you have to have as soon as you have a patient with shock, you should obviously go in for a 2D echo. Step 1, look at the pump. Step 2, look at the tank. Tank, as I said, is basically the IVC assessment where we look for the IVC size and variation. You look for the leakiness of the tank in the form of presence of B lines. Now, if you're pumping in fluids into the patient and you're seeing that the lungs are suddenly starting to get a lot of B lines. So obviously the fluid is leaking out into the lungs, and obviously no further fluid therapy should be given. Otherwise, this patient is going to flood and drown in the fluid. So here you're going to stop the fluid therapy and give vasopressors instead. And at the same time, you can look for where is all the volume going, whether it's going into the abdomen in the form of free fluid, is it going into the thoracic cavity in the form of pleural effusion, and so on. And finally, look for tank compromise, that is signs of pneumothorax, which is loss of lung sliding, presence of lung point, basically a A- profile. If you find that, this is a sign of a lung compromise. So this is the pump, this is a tank, and as I said, the pipes is a DVT assessment. So putting all these three things together, you can have a stepwise approach to shock. You can subclassify shock into cardiogenic, hypovolemic, obstructive, and finally septic. So this is the broad division which you can do with a bedside ultrasound. And mind you, bedside ultrasound is not a one-time thing. It has to be done again and again because things in our patients are dynamic. Heart function may be very normal to start with, but because you're giving good amount of vasopressors and inotropes, and as soon as you start withdrawing the inotropes, the heart function will fall. So those things may occur. So you have to reassess the patient every time the hemodynamics change.
It's very enlightened, sir. Actually, sir, we have 1-2 minutes more. So can you briefly some role of ultrasound in neuroemergency like optic nerve sheath diameter or TC? Just briefly, sir. So at least we can cover most of the emergencies or topics.
Yeah, absolutely. So see, it's a holistic approach with ultrasound. So optic nerve, when you talk about neurotrauma or patients with raised ICP, so one thing which you can do is obviously measure the optic nerve sheath diameter. Now, optic nerve sheath diameter uses the fact that the CSF, which is around the optic nerve, which is eventually the nerve, the CSF, and finally enclosed by a sheath. So whenever this CSF, which is in continuity with the intracranial CSF, whenever the CSF pressure increases because of any edema or pressure effect within the brain, it's going to stretch the sheath. When it stretches the sheath, you can see the distension of the optic nerve sheath. And if you measure and you measure it 3 millimeter behind the globe, where the sheath is most prominent, and when you measure it, and if you find it more than 0.5 centimeters, so that is considered to be abnormal. Now there are lots of pitfalls with regard to measuring the optic nerve sheath diameter. See, if the optic nerve sheath diameter is grossly distended more than 0.55 or 0.6 centimeters, then that is obvious that the ICP is raised. Okay, it's a very, very, very sensitive marker and has a correlation of an ICP of more than 20. So that is very obvious. But the problem is measurement of optic nerve sheath diameter has to be very precise. This is, we are dealing in points of a centimeter. Even if you're not in the right plane on the right line, sometimes there could be erroneous measurements. So what is suggested is that you at least take 3 measurements and take it in both the eyes, and then just take an average of all the 3 so that you don't have extremes of measurements which are confounding your results. So you have to make sure the eyeball and the optic nerve sheath is exactly in straight line so that you can take the measure appropriately, and you're measuring the optic nerve sheath from side to side and not tangentially. So once you do that, if you have a measurement of more than 0.5, there's a very high likelihood that this patient's ICP is more than 20. And at the same time, one more thing is that it's a very sensitive marker for raised ICP. It's an immediate marker for raised ICP. But once the ICP is reduced because of your mannitol or 3% or whatever you're giving, the sheath doesn't really spring back to normal immediately. It takes a few minutes to hours. So it's a real-time marker of increase in ICP. You can use it as a bedside device before your CT and all is available to institute anti-edema measures, but it will not be a very great measure to follow up a reduction in ICP. So that is one thing about the optic nerve sheath which one should know. The cutoff value of 0.5 one should know. Third thing, besides this, we can obviously look for pupillary changes. Sometimes the pupillary changes are not very evident, and sometimes it's confusing, especially if the eye is swollen, the eye is shut because of edema, which occurs especially in post-op day 2, 3 of any neurosurgery. You see that there's a lot of edema over the eyelids, and it's very hard to open the eyes in the first place. Or in case of trauma, where the eyelids are swollen, you can't see the pupillary reaction. You can always use the ultrasound to see the pupillary reaction, and you can magnify it, zoom it, and you can flash light from above, and you can just see the pupillary reaction very well. The third use in neuro-intensive care is use of transcranial Doppler. Now, transcranial Doppler is an art which has to be learned. It's a proper course which one has to do to learn how to get the proper readings, how to see the circle of Willis and the three major vessels, the anterior cerebral, the middle cerebral,
a little bit expertise.
Yes, it requires a lot of expertise in that, and then you can, in the hands of expert, you can actually find out whether there's a spasm, vasospasm, there's a reversal of flow as it occurs in brain death. That's pretty obvious. But short of that, whether there's hyperemia, there is increased resistance, there is a reversal of flow, or there's a spasm. So all the four things which you can find out by putting measuring the Doppler values across the various vessels that you see. So this is there. And sometimes, especially if you have a craniotomy, if you have done a craniotomy, decompression craniotomy, and there's no blown flap, an ultrasound is a wonderful device. You can just place it lightly on the scalp, and you actually see images like a CT scan. It's a perfect image. You can actually make out the brain as it is. So that's a very wonderful image. So anytime any of you want to see, if you have a patient of decompression craniotomy, so you can always put the probe lightly on the scalp itself, and you can make out the entire brain in its entire glory.
Definitely, sir. As you said, sir, it's a very vast topic, and we try to cover maximum emergency and the common problem we are encountering in the ICUs. Just before concluding this topic, just any take-home message if you want to tell to our audience.
Yes. With regards to take-home message, see, it is a power tool. As I said, it's a tool which everybody needs to know about, and everybody should learn. At least should be a part of your armamentarium which you have on the bedside. It's a wonderful tool. But like any other device, it has its set of limitations. It gives you just data. It gives you an insight to deranged physiology. There are very rare cases where it actually makes exact diagnosis or pinpoints diagnosis and says this is the cause. It gives you an idea that if the physiology is deranged, why is it deranged in the first place? So it gives you an idea, and then it's up to you to put it into one pattern or a pattern of why this is happening. This is the real-time image of what's going on in the body right now. And what is the cause of this? You have to determine. You have to follow the pathway to determine the cause. And you have to institute measures to reduce the impact of whatever is going on within the body. And you have to follow up real time to see what has been the impact of your measures with regards to the deranged physiology which is going on. Whether the steps which you have taken have really helped. Has it reduced the impact of what is going on, or is it still going on? Is it worsening? All the three elements you have to do. So a repeat scan or repeated scanning is very important. And obviously, it has a learning curve. So everybody has to at least attend some kind of a course to learn and to at least understand what are the things which we can gain by using an ultrasound on the bedside. It's a wonderful device to have a real-time insight into what's going on within the body. And I think that this should be a part of the teaching curriculum for every person who is working in an ICU. So before you can call in the experts, you should be ready with some kind of a diagnosis in your mind, so that at least the steps can be taken. Time is of essence in all our patients. So really, we can't have the luxury of calling a cardiologist on the bedside at the dead of the night and expecting that things will happen immediately, and you have missed out on vital time, which could have been which could have done things to benefit the patient otherwise.
Okay, sir.
Right.
Thank you very much, sir, for being with us. And I will conclude today's topic. Thank you, sir.
Thank you, Dr. Anand, and I thank the organizers of CRITIC for having invited me for this short, brief description of use of sonography in the ICU.